Good day and welcome to IT News. Today's topic is Emergency Department Medical Records. And I'd like to first introduce our team of Keep Calm Nurse On. So Stephanie Anasco, Cynthia Ray, Courtney Snyder, Lisa Sayre, Amaya Seastrand, and I'm Phyllis Snyder. Welcome. Our goal is to look at emergency department medical records, to identify their strengths, to see how we can decrease emergency department throughput, improve wait times, thus decreasing left without being seen and improving satisfaction. So we want to start by going to our clinical site live with Courtney Snyder and find out what some of those challenges are. Courtney?
Thank you, Phyllis. So I want to go on now and talk a little bit more about the problem. Our current problem is that Evidence/CPSI, they've recently changed their name, was originally designed to be used in a rural environment, and it is based on a DOS system. Now that DOS system is very slow, and it requires staff to remember to document certain points. So there's no hard stops or anything like that to prompt our nursing staff or our physicians to ensure that certain documentation is maintained. Our goal with the purchase of a new system is to implement an EMR that supports all of the needs of the staff. And that includes timely service and care. It includes the ability to electronically collect data points, and it must meet meaningful use requirements for Stage 2 and Stage 3, as well as implementation for ICD-10. Furthermore, to elaborate on the problem with CPSI, it's very cumbersome and slow. It's not very intuitive. It takes a long time to switch from patient to patient. The physicians cannot see what the nurses are charting, and vice versa. So it kind of creates a problem with documentation. There's also daily downtime. So at 2 a.m. every day for at least an hour, the system it just goes down and the nurses must revert back to paper charting. That means that no charting can occur between the hours of 2 and 3 a.m. Furthermore, the system drops data. It is created using PDF systems, and if you go to save the PDF, it can drop the data, and there have been cases where we've had to actually take screenshots of those PDFs and print them out to use as the documentation because the system is not allowing us to save it. Also, there's workarounds. The workarounds include there's pre-charting that occurs with nurses, so they will anticipate what a patient is going to need or the events that are going to occur with a patient and pre-chart those so that they don't have to go in and out of the patient's chart. Also, there's printing workarounds, so the triage nurse will triage the patient and then have to print out her triage assessment to bring to the doctor because he cannot see their charting. There's also, if nurses take orders from admitting physicians, they will write the orders on paper charts instead of putting that in the system because it takes anywhere from 5 to 20 minutes to put in a good number of orders. And lastly, it limits our ability to collect throughput data. There's no hard stops for us to collect data and no data mining capabilities with the CPSI system. Back to you, Phyllis.
Thank you, Courtney. So what you see on the screen is a flowchart of emergency department process. It shows as the patient comes in through the emergency department and each individual that they encounter from the triage nurse all the way through the disposition in the emergency department. The E's indicated on the flowchart are those points where emergency EMR utilization or access is required. Now these are just minimum points, so we know that there's a lot of access in the emergency department for the EMR, and every time we go into that EMR it requires additional time. So that results in risks and impact on our patients. We can see that there are delays in care that are built in there. We can see that there are opportunities for missed care. So for example, if a physician goes and puts in or provides an order for medication and the nurse goes and gives it and maybe doesn't document it, or duplicate care where the order is given and the nurse provides that care and goes back and forgets to document it, and then the CPE order comes in, there's a potential for duplicate therapy, which is a patient safety problem. There's inaccurate data that's a risk. Missed charges are something, if it's not documented, it's not something that can be billed for. One of the key elements that it creates a lot of missed charges is the omission of an end time for an IV therapy or an IV push. And then, of course, each time that you're accessing the medical record here, that's resulting in additional labor. And because the system is so slow, it takes additional nurse time, and that ends up in nurse burnout. So as you can see here is the virtual chart for our current system that's Evident, or CPSI. And it's laid out, quite succinctly. This is the nursing view. You can see that there's no access directly to the physician view. So we have no idea what the physician is documenting, and likewise the physicians can't see the nursing documentation. This view here is our physician screen, and this is called ChartLink. The view is much different. It doesn't show, again, direct access so that the physician can see what the nurse is doing, and likewise. So it creates for a lot of disciplines functioning in a vacuum, which then creates the potential for error, and definitely is a patient safety factor. So we're going to go to the clinical site and kind of see how these factors affect our care of our patient. Courtney?
Thank you, Phyllis. So in our efforts to research different types of EMRs for the emergency department, we investigated 3 different EMR systems. One is called T-System, the second is called MedHost, and the third is called ePowerDocs. Now, each system is capable of having an integrated patient tracking whiteboard. It has hard stops and forcing functions for nurses and physician documentation. It also has the ability for doctors and nurses to see each other's documentation simultaneously, and they all have integrated billing. Now, MedHost does not have the ability to have multiple windows open simultaneously and to view multiple patient charts at the same time. However, the operation of MedHost operates from a main patient whiteboard that allows you to click in and out of patient charts very quickly, so it is not a problem for MedHost. All of these systems also meet meaningful use requirements for stage 2 and stage 3, and are also capable of integrating with ICD-10. Furthermore, they allow for data mining and quick capture of data points, and they also function quickly from entry to entry. Now, for this project, we've elected to go with ePowerDocs because it is capable of integrating with the current CPSI/Evident system that we will be using in the current inpatient wards of the hospital, since we will not be changing those. Now, if you can look at the graphic on the screen, there is 2 circles that are the current Evident system that we're using. You can see that the nurse's side of Evident operates completely independently of the physician's side of Evident. Now, the ePowerDocs is the bridge between these 2 systems. Now, the next slide that you'll see is the screenshot from ePowerDocs. On one side of the screen is the nurse's side, in the middle is the order's side, and the other side is the physician's side. Now, all of these tabs can be seen by everyone simultaneously, and so it makes for a very user-friendly and intelligent way to do documentation. Phyllis, back to you in the studio.
Thank you, Courtney. So let's talk about the implementation plan. There are basically 4 phases that we need to go through in order to see about moving this system forward to fruition. First phase is the operational planning phase, which typically would take 1 to 4 months, where we're looking at a needs assessment. What does the department need? What is the budget? What are the resources that we need to allocate so that we can get this product into our place? We have to approach all of the key stakeholders and make sure that everybody's in alignment so that there's not any one barrier that's going to be put up at the last minute that's going to block this device. We want to look at system acquisition is phase 2. That can take anywhere from 1 to 12 months, which is researching the vendor, and that's primarily what our group has done, researching the different vendors to find out which one best suits our facility. We're going to select the appropriate provider. We're going to look at what it takes to purchase that equipment, and is it cost effective, and what is the return on investment. For this particular product, there's a great return on investment in that it's going to eliminate 2 other systems which are costing the facility about $60,000 a year. And the overall implementation of the process is going to save the organization. Phase 3 is the actual implementation, which typically would be anywhere from 13 to 24 months. In the case of ePowerDocs, the implementation phase is about 5 months. 3 of the months takes for CPSI or Evident to build the actual interface to the system. After that interface is completed, then there's about a 2-month period for ePowerDocs to go ahead and create and build the system for the organization. Once that is built, there's a planning phase that goes through the actual implementation at the facility. There would be individuals on site from the company 24 hours a day for 2 weeks. Plus, we're going to be developing and training all the super users. That all happens before the actual go live date. Once we decide what that go live date is and the switch is flipped, everybody's going to be live on the documentation tool. The vendor would actually be there, as well as all of the super users to help support the department in the transition. The last phase is the evaluation, because as we know, whenever you're implementing a system, there are unplanned responses or unplanned and unanticipated findings. And so we want to be able to address those and mitigate those quickly. The vendor on site is great because they can make those quick changes to the system that gets it so that it's our system and very user-friendly. It's going to help meet our goals and objectives in that manner. So, and that also helps with the resistance to change of the nursing staff, because they can see immediate feedback and immediate results with the system, and it's something that's malleable for them. Typical turnaround time for any kind of change in the system is 24 hours for this actual tool. The next step would be data collection, because we want to compare what our former data was on our former EMR to the new system. We want to see that the smart logic and the clinical decision-making tools is actually effective, and that all of the things that we thought were going to come to fruition, meaning some of the smart reminders and some of the flags that are set, are going to help with the financial feasibility of the product. So we want to check the data mining capabilities, look at the turnaround times. Are we getting better door to triage, door to medical screening exam times? Is our length of stay reducing? Is our left without being seen rate decreasing? And is the satisfaction with the staff and our patients improving? Some of those key measures are all targets that we're going to have to see that are improving from the implementation day forward. And we should see kind of an escalating improvement where initially it might be a little bit slow, but as the system is fully integrated and implemented, those are going to continue to improve. We're going to see our quality measures improve, because with all of the hard stops built in for our core measures for acute MI, stroke, all of those items, it's going to help us to be compliant, because it's going to bring up a window saying, you know, hey, did you forget to document this? Or what about this therapy? So that clinical decision-making support is key. ePowerDocs is a robust data mining system, and if there's an indicator that we want to go ahead and add to the pool, we can do that. So basically anything that you can click on in ePowerDocs, we can collect data on. So that would be turnaround time reports, length of stay, volumes of patient, left without being seen. And we can break that down by physician and nurse, which will ultimately help us to analyze, you know, what the barrier is. What are those things that are preventing us from getting to the next level and improving our processes? It will also give us graphical representations of our data. So all of these factors are great improvements in the system and things that we would use the DMAC approach for performance improvement and to go ahead and continue to see the system improve. Onward to Courtney.
Thank you, Phyllis. We'd like to move from this point forward to our reporting plan. After the implementation of ePowerDocs and the phasing out of CPSI/Evident in the emergency room, we would run reports and collect data on the use of ePowerDocs to compare to data collected when we were using CPSI/Evident. Now those data would be compared to each other to determine how effective and how well the ePowerDocs system is working. After that's been completed, we would present our findings to our governing board meetings, our nursing huddles, our leadership team, and all other interested parties, including our corporation that is very financially invested in this change. From that point forward, we would hopefully move forward with integration and permanent use of the ePowerDocs system in our hospital. And that's the way the data drops. I'm Courtney Snyder, IT News.